Hello. Yeah, it's on. Welcome, everyone. All right. All right. I'm Dr. Fowler from UAB and Children's of Alabama, and I have with me Dr. Dennis and our panel of speakers. We will be, this session, let's see, let me get it going. This is the need for comprehensive care, or the comprehensive CF care to be ageless. So when we're thinking of the rationale for this session, I think it's pretty clear to most of us that have been taking care of patients with CF for a while. The patients are changing. I'm a pediatrician. Dr. Dennis is adult pulmonologist, and over the last couple of decades, we've seen there's been a transition from there being more patients with cystic fibrosis followed by the pediatricians, and now it's flipped. Now there's more patients with cystic fibrosis being followed by the adult team, and our patients are getting older every year that passes, on average. And this is from the registry highlights, but you can see the demographics of the people that we're taking care of have changed as well. You can see that growing kind of middle-aged population there is the second largest population that there is that we take care of. And, this is a fun slide to talk about, but we're having different problems than we used to have, or maybe you wouldn't call this a problem. Maybe you'd call this something that's excellent. So a new challenge to face, that our patients are having children, and that's very exciting. So speaking today, we'll have Dr. Tracy Kazmierski, and she'll be talking about caring for adolescents and young adults with cystic fibrosis. And then Dr. Sid Kapnadak will be talking about, what is the role of the CF Center in providing primary care? And then Dr. Yoni Buber will be talking about cardiovascular risk reduction. And then finally, we'll have Dr. Stevenson talking about cancer screening. All right. Without any further ado.
Just to add a couple of things, the session is live streamed. So when you are coming to the mic, please speak clearly and close to the mic so that people far, far away can, hear the questions. And I understand it's also live streamed in Spanish. Am I correct? So that's pretty excellent.
Start your timer.
Perfect. I'm Tracy Kazmierski. I'm from the University of Pittsburgh, and I want to thank the organizers so much for the opportunity to speak today. And I'm going to talk to you about Gen Z and Gen Alpha and how we are going to care for adolescents and young adults with cystic fibrosis. These are my disclosures. And I want to talk about these generational breaks. And it is by year of birth, and you can see that on the y-axis here. And really what we're focused on are people born in 1995 to 2009 and then 2010 on. That is Gen Z, Gen Alpha. And you may be looking at this like I did, and you're like, oh God, there's generations behind me, and that really wasn't the case 10 years ago, but here we are. But I think that it is incredibly important that we start to think about these generational differences as we as providers mature. So Gen Z, they are born between 1995 and 2009. They really grew up in this time of the rise of social media and smartphones. And they were influenced by lots of major global events like 9/11 and the financial crisis in 2008. And while they were being educated and they're learning, they transitioned from these traditional learning environments to more digital learning. And Gen Alpha was born in 2010 up to the present time. And really, as they're growing up, digital devices and AI are ubiquitous. A lot of them grew up and had formative years during the COVID-19 pandemic. And they are experiencing a blend of physical and digital learning from a very young age. So I have 20 minutes. I have 18 minutes now. I have so much that I want to tell you in 20 minutes. And these are the buckets that I hope that we're going to talk about in a little bit of depth, but it's not enough time to go into all of this. So I want to point you to a resource by Indiana University that a lot of you may have already taken a part of. But this is an online educational program, and you can see here that course 9 is listed, and it really deals with a lot of the things that I'm going to talk about today on adolescent and young adult healthcare. So you can click on that QR code and be linked to these courses and learn more. So I'm going to ground a lot of what I'm about to show you in the general United States population, and namely from the Youth Risk Behavior Survey. So this is an annual survey of a sample of U.S. high school students, both public and private school educated, that is nationally represented. It's done every 2 years by the U.S. CDC. And it includes aspects of sexual behavior, substance abuse, experiences of violence, and increasingly mental health outcomes. So I'm going to show you some of these trend reports on each of these buckets. And we'll start with substance use. So just to orient you to the slides, and these are from the YRBS, they have these like stoplight systems where green is in the right direction, the yellow triangle is no change, and then the red stop sign is in the wrong direction. So this is the percentage of US high school students who currently drank alcohol, and you can see that in 2013 it was 35%, and 2 years ago we were down to 22%. For current marijuana use, again, a decrease from 23% to 17%. Other illicit drugs is decreasing from 16 to 10%. And then they added some of these questions as we went through time in the opioid epidemic, misusing prescription opioids is at 12%, and then currently misusing prescription opioids is at 4%. So those are all nice green arrows. But I want to say that there has been some data around substance use in cystic fibrosis. This is a survey study of over 1,000 people with CF ages 18 years or older that looked at alcohol use in the CF community. And what they found in this survey is that 77% currently consume alcohol, 18% formerly, and 5% never. They also found that among those who currently consume alcohol, a little over half met criteria for excessive alcohol use, and 30% experienced harmful symptoms of alcohol use. And males had a much higher odds of excessive alcohol use than females. What's interesting when we think about Gen Z and Gen Alpha is that age at first alcohol use was the strongest risk factor for having problem drinking later. And you can see that if you started drinking at age 15 years or younger, you had a 5.43 increase odds of having excessive alcohol use later. And that's compared to those who started drinking at legal drinking age here in the United States. There was also a recent study on called Time to be Blunt, which I think is a wonderful title. And this is a survey that looked at marijuana, CBD, e-cigarette, and cigarette use in 226 people with CF ages 13 and older. And they found in the prior year, among those in this age group, 27% used marijuana, 20% used CBD, 37% used e-cigarettes, 29% used cigarettes. And I just want to pause and say, tobacco use is not included in what I'm showing you from the YRBS data that I showed, but there is a mountain of evidence that this is not good when you have cystic fibrosis. So I'm going to give you bullet points of all the bad stuff that tobacco smoke causes. And the citations are at the bottom. But there's been studies that show tobacco smoke reduces the functional expression of the CFTR gene and inhibits ion transport. Cigarette smoke leads to acquired CFTR dysfunction in people without CF. Smoke increases airway inflammation and impairs pathogen clearance in people with CF, and they have worse lung function and more exacerbations. And then finally, and I think really importantly, there's been data that's come out recently that smoke exposure impairs the efficacy of CFTR modulators. So this is really important to think about. So why would teens and young adults ever smoke or use substances? And, there's lots of reasons and motivations for people to do this, and you can see those on the screen. But I think it really begs this idea that we need to ask, and we need to ask about substance use. And indeed, the American Academy of Pediatrics recommends universal screening starting at age 11 at every clinical encounter. And I think this is really hard because what do you do when somebody says yes? And I think it's outside the scope and the time that I have to talk about, but I think it's important to think about counseling on quitting or providing resources that are nationally available. Nicotine replacement therapy is something that lots of pediatricians and my adolescent medicine colleagues think about, and I often partner with them on. Our mental health professionals on our team are often very good at talking through people's motivations here. And I think strong partnerships with PCPs and other providers is an area of growth for the CF community, especially as our population ages. So let's turn to sexual and reproductive health. Same thing with the stop signs and the green equals go. But this is among US high school students again. The percentage of high school students who ever had sex has went down from 47% in 2013 to 32% in 2023. Having 4 or more lifetime partners has also decreased to 6% in 2023. Current sexual activity is about 1 in 5 at 21%. But concerningly, condom use during the last sexual intercourse really hasn't changed that much. It's still at over half. They started asking about effective hormonal birth control in the 2021 data, and about a third of high school students who are sexually active are using that. And STI testing and HIV testing is still pretty low and not changing that much. I've talked about this a lot. I just want to remind everyone that adolescents with CF have sex at the same rates with the same number of partners and about the same age as the general US population. And they're not receiving the same reproductive health care. We've done surveys of adolescent and young adult females with CF, where we found they were significantly less likely to have been tested for STIs in the past year or to have ever used contraception. That's among females. Very recently, we published in the Journal of Cystic Fibrosis of a sample of 532 males with CF, ages 15 years or older. And we found that only 32% had ever been tested for STIs, and only 14% reported receiving STI counseling ever. Among those who were sexually active with 2 or more partners in the prior year, 36% reported never using condoms. And this really extends beyond the US. This is some data from France looking at children and adolescents who are eligible for the HPV vaccine. For those of you who were at physician ground rounds, we saw a lot about HPV this morning. And we found, they found that 69% are unvaccinated for HPV. There are adolescent-specific educational resources that Boston Children's Hospital has put together at youngwomenshealth.org. And there's the link right there. But also the CF Foundation has wonderful resources on their website on sexual health. So these are 2 things when you're thinking about those Gen Z and Gen Alpha people who you are caring for. These are 2 resources that may be helpful to share the websites of and with. I want to take a minute to address gender and sexual minority folks, because as you can see from this slide, it's increasingly important. So the Gallup poll is conducted in the United States, and in the 2024 version, nearly 1/4 of Gen Z adults, which were ages 18 to 27 at that time, identified as LGBTQI+. We're actively studying this in the CF community and undertaking what's called the Pride CF study. And it's really to explore that interplay between having CF and being a gender or sexual minority person and having that lived experience. So this QR code connects you to the study, and you can get updates on what we're finding and what opportunities there are for people with CF and their families to participate as this goes forward. I'm going to come back to this population in a little bit, but I just want to move on and back to mental health among all US teenagers. Everything's a red stop sign on this slide, except for one. The percentage of US high school students who experience persistent feelings of sadness or hopelessness has risen from 30% in 2013 to 40% in 2023. People who are experiencing poor mental health is at 29%. 1 in 5 students that they surveyed seriously considered attempting suicide. 16% made a plan. 9% attempted suicide. And 2% were injured in a suicide attempt that had to be treated by a doctor. When we think about US LGBTQI+ students in this same survey, 65% experienced persistent feelings of hopelessness or sadness. Over half had poor mental health. 41% seriously considered attempting suicide. 31% made a plan. And 1 in 5 attempted suicide. And I just want to call out that it is not the fact that you are a gender or sexual minority person and that identity itself that leads to these mental health concerns. This goes through a lens of discrimination and stigma in our society that leads to these mental health concerns. So why is this happening? And I think that there are lots of reasons and lots of contributors to this. And I just want to highlight a few, and this is not exhaustive. Some of you may have heard this idea that Zoomers are doomers. And if you haven't heard that phrase, it's really this idea of extreme pessimism, especially about the future, often to the point of believing that societal collapse or a catastrophic event is inevitable. You may have heard this and you may have said, how common is that? Well, in Lancet Planetary Health in 2021, they did a very big survey. And by very big, I mean they surveyed 10,000 people age 16 to 25 across 10 countries. So 1,000 people a country. And they found that most were worried about climate change. 59% endorsed being very or extremely worried, and 84% at least moderately worried. Over 45% of respondents said their feelings about climate change negatively affected their daily life and functioning. 3/4 said that they think the future is frightening. And 83% said that they think people have failed to take care of our planet. When we look at the Youth Risk Behavior Survey, more than 3/4 of students who were surveyed use social media several times a day. And I think this impact of using social media so often is an active area of study across disciplines, healthcare, sociology, psychology, you name it. But I want to highlight a couple things that we do know. So there was a study that recently came out this year, and this was a self-report survey of 2 million people in 163 countries. And what they found is smartphone use by children less than age 13 was associated with suicidal thoughts, worse emotional regulation, lower self-worth, and detachment from reality, and this was especially true among girls. Smartphone users access social media more and experience sleep disruption, cyberbullying, and negative family relationships. And I just want to call out a book that I think many of you have read or have heard about that talks about smartphone use and its impact on mental health, which is called The Anxious Generation. And it's this great rewiring of childhood causing an epidemic of mental illness. So this is something that you are hearing in the media and is something that our patients with CF and their families are certainly not immune to. Has anybody watched this? Yes. Okay. This is a Netflix show called Adolescents. I will disclose that I was not able to actually sit down and watch this because it is incredibly upsetting. But really, what I want to talk about is something that also is on the internet called the manosphere. And this is a network of online communities that are promoting negative, often misogynistic content. Now, the UK, which is where Adolescents was, the show was come out of, did a lot of research into what is the manosphere, how common are people and children engaging in this and experiencing this. And I'm going to show you some statistics from that group now. So they found that on average, boys age 11 through 14 are exposed to harmful content within 30 minutes of being online, and 1 in 10 are seeing it in as little as 60 seconds. Over half are aware and have engaged with content from influencers with ties to the manosphere with this negative misogynistic ideas. 2/3 of boys stated that seeing harmful content online made them feel worried, sad, or scared. 59% are accessing this content through innocent and unrelated searches, and then they're fueling online algorithms and getting it more quickly and more often. This is the most concerning part to me as a parent, that 22% have noticed a gradual change over time in the language their son uses to talk about women and girls. So there is a lot of media coverage about this and ideas that, how are we combating this and what are we doing as a society? Wait Until 8th is a group that it really is hoping that parents will sign this pledge to not allow smartphone use until 8th grade, which in the United States is around age 13 or 14. But in addition to that, I think it's important, and some of the key things that I read as I was going to prepare this talk is really exploring online together with your children or talking with your patients and their families about this, to encourage reflection and media literacy, to understand, why is somebody showing you this? Why is it being shown in this way? And some of these open-ended questions are things that I've used with my own children. How are boys in your class talking about girls? Or have you ever heard of X, Y, or Z? So I just want to say that was all very scary. It was very scary to me to prepare these slides and to think about this. But I want to end by saying we shouldn't be afraid of teenagers and young adults. They are our future, and they really carry our hope and what we're going to see in the future. And I personally believe that it's going to be bright, but we have to help them. And with that, I'll end. But I want to thank a few people first: Sarah Robb, Asher Prangley, and Olivia Stransky, two of which are here, who looked at these slides and who said, yeah, that's what you need to include, or no, you need to do more. But I also want to thank my sons, Grant and Patrick, and my own Gen Alpha. So thank you very much. Yeah.
Please come over, for anybody that has any questions for Dr. Kazmersky, who did an excellent presentation.
Tracy, great talk. And of course, you encapsulate a lot of the challenges that I think we as clinicians and care teams face when we're talking to families of kids that are in the pre-adolescent, adolescent, and young adult years. I'm just going to challenge a little bit this notion that we don't want to encourage or think about how technology might help our families too.
Yeah.
Because I think that there are also efforts to, work on how are you understanding CF as a chronic illness, or how are you managing your medications, or how are you remembering to take your enzymes at school, or taking your modulator. And I think a lot of us do turn to tools.
Yeah.
There's a lot of work on, remote monitoring. And as we're seeing our patients less and less, I think we have to be careful to say that technology is all evil, and we want to think about how to, particularly in our role as CF clinicians, think about where we're using technology safely. And so I'm just curious your thoughts on that.
No, I completely agree with you, and I think smartphone use is really what you're describing, because there is this. Smartphones are helpful, right? Like, I had a BlackBerry at one point, and that wasn't very good. And I think that it can be a tool in your pocket to help you do things better. But it also is something that can open you up to lots of things. Some of the stuff that I talked about. So it needs guardrails. And I think that we as providers really need to help our parents and families think about the guardrails, but also, yes, leverage it to help people take care of themselves and their children.
So thank you. Jeff Gold from OHSU. Fantastic talk. I guess I'll say maybe the really controversial thing, which is, so no one yell at me, please, which is we have built up over the last 50 years, 40 years, a CF ecosystem that is based on social isolation.
Yes.
Right? You're going to get sick if you talk to anybody. CF patients can't hang with one another. There's no more CF camps. And what did we tell them? Use social media to get in touch with people. Mm-hmm. We are in a new era of modulators now. At what point do we as a society or as an organization say that maybe we need to readdress those rules, that the risks outweigh the benefits of our current isolation policies? Because what we're doing is, by definition, shunting people towards these modalities, which I think may be even more harmful. And again, I'm just going to say, y'all can yell at me later, but it is a different disease. We sometimes have to, you can't always have sacred cows. You sometimes have to make sacred hamburgers.
I think that's a great question. And I think that one of the things that my team suggested I include was talking about influencers in social media who are really positive for people with CF and CF teens, and who really could be a resource and something that they can use to help them. But I think for each person online who's saying something that's evidence-based and wonderful and all of those things, there's somebody who's saying something that's not quite right. And may be harmful. I just didn't have time to go into it, but I think that it's really important that when we think about using it for peer connections or social media, that we're educating them about the intent and the content. You'll notice that I didn't talk to you about the infection control question, but I do think that that is a conversation that we need to have our infection control folks and experts in the room with, to have that conversation together for lots of reasons. But I think that CF is changing, so we need to think as we can't just plod along and do the same thing.
Tracy, I have one last question from the audience. And this is a person who identified themselves as having, cystic fibrosis. And they express frustration about the fact that us as CF providers, and this is unfair to give it to you, as an adolescent medicine person, we don't talk about perimenopause use for estrogen, for perimenopause use, and how this is, an important health, medication it has implications for symptoms, for breast cancer, for stroke, and how do we educate all the physicians like we've done for everything else? We're pulmonologists, but we're also kind of, facile in treating a lot of things that are related to the CF the way we knew it before. So that's a comment, basically, and comment also that was told that for age 44, too young for, estrogen replacement therapy. So if you want to handle it or say any comments, please go ahead.
I think this is something that is very prevalent in the general population as well as among people with CF. And I think that there's active research going on perimenopause and menopause in CF care as part of the Sharing Research Working Group. So I hope that we had a pre-meeting to NACFC 2 days ago, and we spent a lot of time talking about what are the ongoing projects and what are the projects in the pipeline to talk about menopause and talk about how we actually treat people with HRT in our specific subpopulation. So I'm hopeful that there's going to be some larger studies looking at this coming down the pipeline that we can hopefully be enrolling at multiple sites or even in a decentralized way. But I think the community is telling us loud and clear, we need to address sexual and reproductive health across the age spectrum, and that includes perimenopause and menopause.
Thank you. Perfect.
Yeah.
So, I know she's got to run, so if I get a chance to find you later in the conference, I'd like to ask you about your partnership with adolescent medicine and how you take care of folks who are using substances.
Yes.
Yeah.
I sit within adolescent medicine. I am a pulmonologist, but I think that partnership, if it is available at your institution, is invaluable because they have the resources, expertise, and clinical specialty to talk about a lot of adolescent and young adult issues including things that I didn't talk about, which is transition and being ready to transition to the adult side. And I think that they have been invaluable partners for me. But there's probably more work that we can do to strengthen those ties. But you have to play on what resources you have in each of your institutions and what opportunities there are to do that. But I think it's been a really great partnership for me at my institution, but it's something that we can always do better. Thank you, Miles.
Thank you, Dr. Kazmersky. So Dr. Kazmersky is in high demand, so she's going to have to go to a different, session. So if you have questions, please send her, the questions via the app, and hopefully she can answer you. We're going to go to our next talk. I'm going to introduce Dr. Kapnadek, who is the adult director for the program of cystic fibrosis at the University of Washington, like where we are. He's hosting us. He also does advanced lung disease and transplant. He's an associate professor of medicine at the University of Washington and was also instrumental in writing guidelines for advanced lung disease. So today he's going to talk to us about primary care and CF partnership.
Thanks, Dennis. Can you guys hear me? Thanks, everyone, for coming and for the invitation to speak by the organizers. Like Dennis said, I'm going to be talking about primary care in CF, and I called it why, who, and how. I don't think I necessarily have all the answers, but I hope this will be practical and useful for you all. I don't have any disclosures. So my objectives for today are going to be to first review some of the medical issues that are becoming more important in the modern era of adult CF care. And Tracy focused in on the adolescent population. I'll be speaking basically exclusively on adults. I want to review the benefits as well as the barriers to primary care delivery outside of the CF clinic. And then last, I'm going to provide a suggested approach based on our own center's experience with collaborative primary care and some of the efforts that we're currently involved in. So first, I want to start with the case. This is a 43-year-old. She is a 508 del homozygous. She's been on ETI since 2020, doing well from a pulmonary standpoint, normal lung function, no complaints there. She has impaired glucose tolerance. Her BMI is 31, and she's gained some weight on Trikafta, and then depression. Some of the issues today, her blood pressure is elevated in clinic. She has a recently elevated LDL cholesterol, and this all kind of ties together. It's kind of nice. She is concerned about perimenopause. She's noticed some early symptoms of hot flashes and mood changes. And she also asked about the impact of her oral contraceptive on weight and cardiovascular risk. So she's been on this for years and asks about it today. So I don't know if this resonates with anybody, a person coming into adult clinic with a bunch of issues that need to be addressed, none of which are related to the lungs or digestive system. This is certainly not all of our cases, but I do think it's illustrative of the type of cases that we're seeing more often in the modern era. And the CF healthcare landscape is certainly evolving. This is a great testament to all of the hard work that is being done and has been done in the CF community. Outcomes are improving, and we're seeing older patients. So the U.S. CF population is now about 60% adults, and almost 20% are greater than 40. These numbers are even a little bit higher in Canada. And with this, people are living longer with some of the well-known familiar CF conditions that we've known for years. And importantly, we're starting to see less familiar conditions develop with age and time. In addition, I think we're seeing, although pulmonary complexity has decreased, we're seeing increased medical complexity. So there are more therapies available, more complex treatment paradigms. And we're seeing engaged patients and families, which I don't think that part is necessarily new, but the ample access to information is much more pronounced. So social media, AI, support groups, MyChart, it's like information overload to a different degree than what was there in the past. So let's focus in on some of the less familiar conditions. Certainly obesity is important. This slide shows pediatric data on the left and adult data on the right. And you can see that the percentage who are overweight or obese has increased from about 10% to 21% over the past 20 years in children, 18% up to 43% in adults in 2024. This brings about many other less familiar issues. This study was out of Montreal. They looked at about 300 patients and in their adult clinic and classified them as underweight, normal, or overweight based on the BMI categories that you see there. The overweight cohort was older. And importantly, not necessarily surprisingly, but importantly, you can see that body fat percentage was actually 29% in the overweight compared to 18.8 in the normal. LDL and systolic blood pressure, while still normal, were on the upper end and higher in the overweight cohort. They looked at insulin sensitivity index, which incorporates a person's body weight as well as insulin and glucose levels after a 75-gram glucose load, and the insulin sensitivity was lower in the overweight cohort. They followed these patients over 4 years, and a greater than 10% weight gain was associated with a variety of worsening metabolic parameters, including reduced insulin sensitivity. Dr. Buber is going to talk about cardiovascular risks in some detail, but I did want to put one slide in here. This study was from the UK, and they had about 6,000 plus patients in their database. And they showed that having CF was associated with a higher risk of major cardiovascular event, higher risk of myocardial infarction, as well as AFib, and in the unadjusted analyses, heart failure as well. So this is not something that we're used to seeing or used to be thinking about, but in the future, it probably will be a very important topic. And I think we need to ask ourselves this question. So, do we, as CF providers, have the familiarity and the bandwidth to properly assess cardiovascular risks and provide appropriate treatment? We may or may not, but I think we should be asking as adult providers. And this is especially in the era of new therapies, where we're seeing all kinds of new therapies available for various cardiovascular risks. This study shows the use of GLP-1 agonists. So this was semaglutide and tirzepatide in people with CF. Very small case series out of UT Southwestern. They had 11 adults. BMI was 25.7 to 43.7, and 7 had CFRD. And in this admittedly small cohort, all individuals experienced weight loss, and most with CFRD had improved glucose time and range and reduced insulin needs. And it's a small study. We need much more data here, but patients will be asking about this. If you haven't been asked about this, you will. And so we just need an appropriate mechanism to be able to make sure patients get counseled appropriately and referred appropriately and prescriptions if they need them. So going back to our patient in clinic, again, no pulmonary symptoms, and here are the issues that we're focused on today. So weight, depression, blood pressure, cholesterol, perimenopause, the impact of her oral contraceptive on some of these other issues. So nice bread and butter CF case, right? So what would be the questions for this or a similar individual? So how do we manage and counsel her on nutrition? Should we use an antidepressant? These may feel relatively comfortable for the CF clinic. Should a risk calculator be used to guide medical therapies for her risk factors? Maybe getting a little bit outside of the wheelhouse. What is the best contraception choice? Does perimenopause impact these other issues? Should we consider, as the earlier question alluded to, should we consider symptomatic therapies? These might be getting even more out of the wheelhouse. And this maybe I'm speaking for myself here, but this is kind of the comfort level as we go down, right? So on that note, what are the benefits of a separate, trusted primary care provider outside of CF clinic? Well, as I've alluded to, it's very challenging to keep up with the broad knowledge base that's needed for effective primary care. Our adult centers are growing, and this poses increased burden and time limitations on our team, not just the physician, but everybody, fielding phone calls, prescription refills, MyChart messages. And then, of course, easier access to quick and problem visits for patients who have acute issues. This study is from UNC. It was from 2020, and they looked at 92 adults in their center. 59% had no PCP. And they looked at the percent of adults in their clinic that were meeting US recommendations. And you can see that the clinic did fairly well on depression screening, alcohol counseling, diabetes, and smoking. That's not too surprising. Colon cancer and osteoporosis, not quite as great. But then you can see here the low rates, and Tracy talked about this too, the low rates of some of these other issues, STI counseling, cervical cancer screening. And it kind of makes sense, right? We see a patient in clinic, whether they're up to date on their pap smear is not necessarily priority 1 on the list. You'll notice that some of these are women's health related, including cervical cancer, mammography, and others, including Tracy, have shown significant gaps in preventative care for CF women compared to the non-CF counterparts. And this includes discussion of contraceptives, family planning, and discussion of menopausal issues. And Tracy touched on that earlier as well. We have a lot of overlap here. All right, so certainly benefits to primary care, but there are also barriers. So from the patient perspective, there may be limited access to PCPs. They may have a hard time finding one. They may already be seeing too many providers or prefer only seeing the CF team. They may not trust their PCP's knowledge. From the PCP's perspective, they may lack comfort with CF, or they may feel that they do not have a defined role. And then finally, there's fragmentation risk. So there can always be conflicting plans or lack of clarity regarding ownership of certain problems. It is challenging to find a PCP. Some studies have shown that up to 25% of Americans and 15% of Canadians lack access to a PCP. It's even more difficult in underserved populations and underserved regions. Interestingly, routine PCP use among at least Americans seems to be declining, especially in younger people and those who are sort of on the healthier side. And we focused in on older patients earlier, but certainly preventative care is challenging in younger patients as well. In fact, one study showed that only 27% of young adults with CF receive routine preventative visits. What else can be an issue? Well, this is an older study, 2006, and what they did here was they interviewed 31 adults in their clinic. This was from the UK, and they did a qualitative analyses to identify themes associated with people's interactions with preventative care in primary care. And one thing that they describe here, which I really like, is this difficult balance between being an expert and a lay patient in PCP settings. And this kind of resonates with me as being a very real phenomenon. And so as an expert, people with CF have all kinds of experience managing their condition. And when they go to the PCP, sometimes they can see that PCP in merely a functional role, so for access to treatments. And this was from a quote in the study. He's there to dispense the drugs and sick notes. I hardly ever see him. Not much use beyond that, which is kind of sad. I think PCPs can feel that, and here in the study, they described that the PCPs were often deferential regarding CF, but at the same time, the physician-patient relationship, as reported by the individuals in the study, was still very dependent on the PCP's understanding of life with CF. So that's a kind of a tough position for both PCP and patient to be in, and it can threaten the trust and the relationship of that relationship, the trust in that relationship. What about as a lay patient? So even though this person is an expert in their CF care, people with CF had a desire to be guided by their PCP, particularly on non-CF issues, which makes sense. But PCPs often don't recognize that switch in role, and it can impact care and undermine confidence. So if they're too deferential, sometimes that can become problematic. And this was from a quote. For the appendicitis, she gave me cramp-reducing tablets and said that I was to eat a lot, and that actually nearly forced it to burst. I think she just put it all down to CF. And so you can see that this phenomenon, I mean, I noticed this in practice, and I think it's very real. This was an older study, but I think it still holds true, at least to some extent today. What are the most important factors when considering a PCP? This study was just published last year from the Foundation Group, Dr. Brown's group, and others. And I've taken one figure from this. They went over a lot of aspects of the care model. This actually just asks the question, what are the most important factors? They had 377 adults, 42 of whom were transplanted, and they also looked at caregiver perspectives. So the important things were communicating well with the teams, and not being knowledgeable about CF and transplant, and being confident making medical recommendations for people with CF or transplant. So those all kind of make sense. And then there were some of the logistical issues, right? Being in network, having available appointments, being close to home. This one I think is the most interesting, and a very small percentage of the people interviewed in this study felt that a PCP was not necessary because the CF team was already addressing all of their needs. But at the same time, 72% of care team members felt that their patients perceived that the care team already met all of their needs. So the patients felt like they needed PCPs, but the care team didn't think that they thought they needed PCPs, if that makes sense. So there's a discordance there that I think we need to appreciate. All right, a suggested approach, and major caveat here is that I'm not an expert in this, but I have thought about it a lot. A lot of these things we're working on right now. So first, review the guidelines and explore what your team may be missing. And there are a variety of resources for this. The U.S. Preventative Service Task Force has a nice website. They have some online tools, both for providers as well as for patients. So review the guidelines. And then determine which items can be provided by the CF care team versus the PCP. So this might be based on bandwidth of the team, expertise, comfort level, or it could be individualized based on patient factors. As an example, our program has grown in volume about 32% since 2015. We're up maybe 350, 360 patients, but our staffing has increased only modestly over that time. So we kind of said, you know what, we have to start thinking about this because sooner or later we're not going to be able to handle all of the issues. Next, review your center's data on primary care and identify PCPs to collaborate with. So we're here in Washington, in our beautiful state, and you get a free geography lesson. So these are our 10 most populated cities. And we looked at the number and location of adults at UW without a PCP in 2020. And about a quarter of them with available data, some of them didn't have any data available, did not have a PCP. So that's actually pretty good. But the darker blue areas are the areas where we had many patients without PCPs. These were kind of the hot zones, sort of southeast of Seattle and northeast of Seattle. So it was helpful to just know where these individuals were. Then kind of zooming in here, the W is where our clinic is on the northeast side of Seattle, and we kind of said, okay, where can we find PCPs to collaborate with? We advertised our clinic. We tried to talk to many people to see if anybody would be interested in collaborating, and we found a handful of PCPs. This is Dr. Holmberg. He's a primary care physician that's close by. He has interest in gender-affirming care and mental health. So those are a very nice resource to have. Dr. Azen is interested in chronic pain and complex symptom management. These are very hard issues to manage. It's nice to have that resource. Dr. Dabalik, she just joined our group. She's interested in geriatrics. These are all family med or internal medicine docs. And Dr. Roy has interest in cardiovascular disease and preventative care. So we consider these our PCP team. And so we've sent them referrals. We can interact with them on cases. They attend our team meetings, and we try to do bi-directional education. In general, we want to make sure that PCPs are designated in the EMR. We send notes and we call regarding difficult issues. Next, we want to educate patients on needs and expectations, and then be flexible. We have to formulate individualized plans and communicate well. So as an example, these might be some of the issues that we say are always going to be handled by the CF team. Whereas these might be issues, vaccinations, obesity, mental health, that may be handled by another provider, depending on the patient. And then we might say, okay, these are issues that should always be handled by the PCP. Just an example here, you can certainly modify this based on the patient and the person. So here's our case. Well, here are the issues that we need to deal with today. And we might say, okay, which issues can we handle versus the PCP? Well, we might say, okay, we have the resources to handle nutrition, obesity, and mental health. But the cardiovascular risk factors and the questions regarding contraception and menopause should go to the PCP. And we'll just be real intentional about this and have the discussion. Open line of communication with the patient as well as the primary care provider. We also have to think about how this will look based on different patient scenarios. So if they're very savvy and engaged and connected, we may be able to put most of that on the patient. But if they're perhaps don't have that health literacy, or they have issues with access to care, we may have to do a little bit more work, like picking up the phone and calling the PCP and doing a little bit more. This is a look at our primary care percentage with the primary care provider in 2025 compared to 10-year. You know what, that's supposed to say 2020, but you can see that we've had some increases there. All right, so in conclusion, I think the future is very bright for people with CF, and the fact that we're talking about this really speaks a lot to the accomplishments that have been made. We will need increasing knowledge about some of these less familiar issues that are becoming more common and important in the modern era of CF care. And then finally, I think collaboration with PCPs in the community will be crucial to ensure optimal care for individuals with CF. Thanks. Happy to take questions. If anybody wants to do evaluations, you can follow that QR code. Tracy already talked about the online CME program too. If this is a very nice resource for a variety of issues, if anybody wants to peruse. All right. Hey, Jeff.
Hey, Sid, how you doing, man?
Good.
So you talked a lot about what is going to be the strategy to demystify primary care for the CF provider. But what have you guys been able to accomplish at UW for demystifying CF for primary care? So in other words, getting to the family medicine residencies, getting to the medical students, and helping build this into their curriculum so that we train the next generation to not be scared of CF as something that only belongs to a center.
No, it's a great question. I think that contributes a lot of times to that deferential relationship, because it's such and we see this with our transplant population too. It's kind of like, we don't want to touch this person because we're afraid that something's going to happen. And what you're saying is super important. We've started by sort of honing in on our own providers at UW, lecturers, trying to educate the residency program and so forth. How to get it out more broadly, I think we're just trying to kind of chip away at it. So, we've given talks for the residents, we've given talks for primary care providers in our system. We've sort of hooked up with these various clinics in our region to kind of get the word out there. But I think, it's just sort of a matter of chipping away and, getting that, because most folks out there, most primary care providers don't realize how long a lot of these people are going to live.
Well, and last year I sort of made the pitch, and I'll make it again for anyone in the foundation who's here, is we have maybe use some of these resources to set up a speaker series where we could be going out, where you take experts such as yourself, not just at UW, but there's a lot of even medical centers, residency programs, et cetera, around the country that don't have CF centers, so they don't know anything about the disease. And where we become the traveling roadshow as the experts to empower people around the country. And so that's what thing that the foundation could and should support.
It's a great idea. Thanks, Jeff.
Hi, great talk. My name is Dale Mazer. I'm a Gen Med adult primary care internist taking care of adults with cystic fibrosis. There are at least 3 of us in this room. I might be missing others. We just came from a lunch by the Program for Adult Care Excellence, which is a program by the CF Foundation to generate people like us to do what you're talking about doing. One of the ideas that came out of the lunch today, thank you, Whitney, was that one of the ways to encourage primary care docs to not be afraid of CF patients is to encourage them to get to know the CF team. So the way my center is doing it is I'm embedded with the CF team in the CF pulmonary clinic. And the relationship I have with that team is so remarkable and so much fun and so educational for me. I mean, I'm hoping I'm taking good care of patients, right? But I'm learning so much. I'm feeling super supported. And so the idea of taking care of patients with cystic fibrosis just isn't nearly as scary as I certainly believed it to be 2 years ago.
Thank you. Yes, and which system did you say you were coming from?
University of Michigan.
Michigan. Yeah, and this sounds similar to what we're trying to do with a few of our PCPs in the UW system. And I think it's wonderful. And when I can speak to our experience, we've tried to integrate our PCP team into our meetings and events and things like that to get to know them. And like I said, I think the education is kind of bi-directional because I've asked our PCPs a lot of questions about general health maintenance questions, things like that.
There's a couple of questions from the audience. You partially, I think answered one of them. So one is, how did you engage with your PCPs that you brought up? Did you cold call them? Did you find them? And then the second one, I'm going to give it, is added complexities when you have transplant patients, because those might need a transplant team visit, a CF team visit, and now a PCP. So how do you, kind of handle that?
Yeah, so the first question, we have worked exclusively within our University of Washington system, which is, we have a lot of clinics all around the Seattle area and extending even beyond. And so that was a little bit easier just to sort of message out to the leadership within general medicine and see who might be interested. And we kind of surveyed on what various PCP's interests were. And then I just individually emailed a handful of people, and some were interested, and so they kind of, that's kind of how we addressed it. Now, if we go back to our big map there were many regions that were not in places within the UW system, and we could potentially reach out to folks in those regions as well. Maybe if we had one person with a good experience, we could always reach out to them. That's kind of how I envisioned it. Is, if we see somebody who's getting good primary care in the Tri-Cities, we might reach out to that provider and say, hey, would you be interested in taking on more? So that was kind of my vision there, although we're just sort of starting it now. And the second question was about transplant.
Because you now add 3 teams, basically.
Yeah, so that, I think it's a case-by-case thing. I think there's, the transplant guidelines have some various models of care where, if you have somebody with CF post-transplant, this person can be managed by both teams, one team, or some variety of shared care. And I think the same can be true of primary care as well. It's sort of a case-by-case thing depending on how far away they live, how good of a relationship they have with their PCP. But I think there needs to be sort of a checklist of here are the items that need to be done, and just an intentional conversation of, okay, here's what you need to do and who's going to take care of it and how do we implement that properly.
Hey there. As a CF mom and a nurse too, I was curious, since I still have a teenager, if there's talk with this primary care topic of transitioning from primary care pediatricians to adults, and kind of, I know that Seattle Children's and UW have what sounds like a great transition to adulthood program, and I was just curious if primary care comes into that.
Yeah, that's a really good question. Our transition program has been primarily the pulmonologists, and I think that seeing that that's a vulnerable time with a lot of stressors, we've maybe half intentionally tried to keep it with just the CF programs, just to not add too many wrinkles to the transition plan. It's a good thought, though, especially as younger children, adolescents, more, and I didn't talk about pediatric primary care or general pulmonary care as a pediatrician, but I think there is a vision that many of those children and adolescents have a separate pediatrician managing many of their issues, and then with that transition over to the adult provider. I think that would be great. I think we in our program have tried to keep the transition relatively focused, just to not add too many pieces. But yeah, it's a great thought. I don't know if, Whitney, if you have other comments.
Hi, Whitney Brown, CF Foundation. We were just talking about that in the PACE lunch, and somebody asked a very similar question as to whether, like sickle cell and some other chronic diseases, there should be at least an expectation laid out when someone transitions to adult care, that just like you had a general pediatrician, you'll also have a primary care doc. It's kind of your teams are changing. This is a bundle of care. I don't know that people have been doing that because we've been, I think, fearing overwhelming families, but someone who was a transition specialist, I think it was Neil Emery from our group, was saying that he takes care of kids with sickle cell and other chronic diseases, and that is the expectation. So I think it's something we should think about.
I had a quote in there from that JCF paper from last year in Malhotra, and I took it out, but they said basically that seeing that there's such a low rate of preventative care in young adults, that's 18 to 27, that we should be very intentional about making sure that these people have a primary care physician, even when they're in their early 20s and don't have a lot of issues to primary care, just to get those habits in and make sure people are getting, and we see this like HPV vaccination, pap smears, things like this that people aren't probably getting as well as they should.
One last question, hopefully it's brief.
Hopefully it'll be brief. I'm Karina Whalen. I'm from UNC. I'm also a primary care doctor who provides primary care to people with CF. We're still building out our model because we have a large catchment area. We have patients that come from far away, and we're trying to figure out how to get other PCPs kind of looped in. I was curious, the 4 providers that you had, did they get like time supported to kind of engage in this? Was this something that was supported through like a grant? I have the PACE award and that's helping me. Is it something that, your CF center? I'm just like trying to think about how you incentivize a very busy primary care provider who has a bunch of patients to take out the time to learn about something.
It's a great question. For our 4, we sort of, called attention to the PACE Award and kind of not advertised, but we made that a part of the discussion so that they knew about it. None of them have taken the next steps quite yet, but we remain in. I mean, we'll keep discussing with them, and I think that that's a really nice opportunity. Outside of that, it's challenging. Just the way. I mean, it's all about sort of productivity now, and it's really hard to kind of take away clinical time. But so we've tried to outline expectations where we try not to overwhelm them. We say you might get a couple patients a year, and you be part of our team. We try to show them how great CF is and how great our team is, and we hope that that's enough incentive.
Thank you.
Next, we're going. Hello. Yep. Next, we're going to hear from Dr. Yoni Buber from the University of Washington Medical Center. He's going to be talking to us about cardiovascular risk reduction.
Okay. So Sid has really set the stage for me. Thank you. And hello, everyone from that middle area of the thorax. I think that the fact that I need to stand here and speak about cardiovascular risk prevention in patients with cystic fibrosis is really a testament to how great you've all been doing in keeping your patients alive, so this would be even relevant for them. And I'm going to definitely dive into the nitty-gritty details of cardiology. We have 20 minutes for that, so might as well get started. I have no disclosures, and this is going to be the outline. I'm going to review the incidence of what we know, and Sid have shown this in his previous talk about the incidence and risk factors for heart disease in CF patients. And then I'm going to move a little bit out of the CF world to the general population, because I think that your patients are getting there. Define risk factors for early onset cardiac disease. Do a step-by-step risk stratification and treatment options with focus on cholesterol and hypertension. And then my take on a look into the future of the CF patients and heart disease. So again, thank you, Sid, for showing this study before and stealing my thunder. But this is the best piece of data I think that is out there, at least based on the research that I did for this talk. This is a publication at 2023, looking at 5,000 UK cystic fibrosis patients and over 6,000 CF patients that were taken from the TriNet X network. It's a good source for research, by the way, for those of you who are interested. The analysis was done with and without propensity matching to the general population. And these were the demographics. So the average age was 32 years in those patients. 45% were women. The average BMI was a little bit lower than what we heard before, 23, at least in this study. And there was very low incidence, which was kind of impressive, I think, of hypertension, high cholesterol levels, and expectedly high incidence of diabetes. Major adverse cardiac events, which was the outcome, or MACE, occurred in 7%, as you've seen before, in the CF patients versus 1.5 in the general population, yielding a hazard ratio of 1.65. And this is the slide that was shown before. The outcomes that the authors of that manuscript looked at were MI, heart failure, and atrial fibrillation. And as you can see here, when adjusting to the general population, MI and atrial fibrillation were still more prevalent in CF patients as compared to the general population. Heart failure was not. And so in my general cardiologist eyes, when I look at these numbers, I had two insights. Number one, the amount of risk factors or the degree of risk factors that your patients have is really not terrible, or it's actually pretty good. 2% of cholesterol, blood pressure was fine. But number two, 7% incidence of heart disease in a patient population at an average age of 32 is really high, despite the lack of risk factors. And there must be something else going on. And the other thing that is going on, and I think that you all know this, is chronic inflammation. And chronic inflammation was the other thing that the authors of this study looked at. And what they did is they did another propensity score matching for patients who have chronic inflammatory diseases from the same TriNet X network. Looked at patients with lupus, rheumatoid arthritis, and HIV. And if you look at the right-hand side of this table, you will see that after that matching, the incidence of heart disease was about the same. As compared to lupus and HIV, maybe slightly higher than rheumatoid arthritis, just meeting that one threshold. And we all know that chronic inflammation is a big risk factor for cardiovascular disease. We know that it causes plaque buildup and plaque destabilization through direct effects of pro-inflammatory cytokines such as IL-1, IL-18, TNF, and so on. It also activates fibrinogen and PI1 through IL-6 action on the liver, which do the same thing. They create the plaque and destabilize the plaque. And we can, of course, test those inflammatory markers on blood samples, mainly checking CRP, but also IL-6. And CRP levels have been shown to be associated with high risk of cardiovascular disease. In our general population, not hyperinflammatory patients, but general population, a cutoff of 2 is shown to be associated with pretty high risk of cardiovascular disease in the next 10 years, even when adjusted to other cardiovascular risk factors, as you can see here in the red bars. So when I prepared this talk, I thought to myself, well, I can just stop here because your patients have diabetes, they have high inflammation. I don't know that there's much to do about that. The other risk factors are not, at least in that study, did not come out significant. Thank you very much for your attention. But then I saw this, and you saw these numbers at least once or twice during this session. And this is the survival trend of your patients. And we're probably looking at more than 60% being adults of over 18 and less than 40% being in the pediatric patient population. And so I think that your patients are getting there. And maybe those risk factor numbers were outdated, and we're looking into higher degree of or more hypercholesterolemia, more hypertension in the near future. And so for that, I'm going to zoom out and start talking about risk stratification for cardiovascular disease and how we do it in the general population, because I think your patients are getting there. So the most commonly used risk tool that we have is the ASCVD risk stratification tool, and you can find it in this website or just download it. There's an app. It gives you your patient's 10 risk chances of developing cardiovascular disease, and it divides it into low, intermediate, and high risk group, as I will show in a minute, with the actionable item being starting on statin treatment. That's the recommendation that this thing is going to give you. The data that you have to plug in there is the age, sex, race, blood pressure, cholesterol, with a breakdown to HDL and LDL, and then diabetes, smoking, etc. Some patients should not be screened by this tool because they have a higher risk and they need to be on a statin anyways. Those are the patients who are already had a cardiovascular event like an MI or a stroke, patients with confirmed familial hypercholesterolemia or like really high LDL level of more than 190. And then relevant to the CF patient population, patients with established diabetes, although these guidelines will tell you that the cutoff age for that would be over 40. Otherwise, these are the numbers that you get. Low risk of 0 to less than 5%, borderline 5 to less than 7.5%, intermediate 7.5 to less than 20%, and then high risk for cardiovascular disease in the next 10 years of more than 20%. There are some cardiovascular risk enhancing factors. As you can see here by this red arrow, it says ASCVD plus. And so here's the plus. It's a long list. I think those are the risk modifiers that could place your intermediate risk patients and maybe do refinement to higher or lower risk if they exist, probably towards the higher end. I think that the most relevant for this talk is the one at the bottom that I highlighted in orange, chronic inflammatory states. But other things include LP(a), so popular in the cardiovascular literature these days. We don't have a specific treatment for that, so we still use it for just risk stratification, metabolic syndrome, CKD, high-risk race ethnicity such as South Asian ancestry, and family history of ASCVD. I want to pause 1 minute about ASCVD and talk about atrial fibrillation just for one slide because the authors of that study have included that as an outcome. And I thought that was a very good idea. They should have done that because when you look at the risk factors for atrial fibrillation, they're very similar to ASCVD risk factors. And they include smoking, they include obesity or high BMI, definitely diabetes, definitely hypertension, and once again, those inflammatory markers. So that's an important outcome to look at and something that will be probably down your alley with your patients. So what do we do with this risk tool? It's a busy slide, but by this time, you know about half of it by heart. On the top right are the patients who should not be screened by this tool. Bottom left are the risk enhancers. And then we look at age groups. I highlighted in light blue the patient group that is probably more relevant for this talk, 20 to 39 years. And we would recommend taking a statin if they have a family history and LDL cholesterol of more than 160. If they have more than 2 risk enhancers, you can move 1 square to the right to the age of 40 to 75. And then when we zoom in on what to do with that age group, those are the recommendations. For the borderline risk factors, it's a shared decision-making and a class 2B indication to start a moderate intensity statin. For the intermediate risk, it's a class 1 indication to start moderate intensity statin to lower the LDL by 30 to 49%. And those statins you can see here at the bottom, atorva 10 to 20, rosuva 5 to 10, or simvastatin 20 to 40 milligrams if you can still find simvastatin anywhere. For the high-risk patients, the class 1 indication is to start high-intensity statin to lower the LDL cholesterol by more than 50%. And we do that with atorva 40 to 80 or rosuva 20 to 40 once per day. Let's move to the other part, which is hypertension, how to screen for it, and how to identify risk factors. First of all, I think that it's important to review the guidelines and what they tell us about what is hypertension, because those numbers have been all over the place for the past 10 years. The current guidelines tell us that stage 1 hypertension is 130 to 139 millimeters of mercury for systolics, 80 to 89 for diastolic. And the more severe hypertension, stage 2, is over 140 or over 90 for the diastolic, which used to be the previous definition of hypertension. We're also looking at elevated blood pressure of 120 to 129 with the aim of looking or following those patients more closely. In the general population in the United States, the prevalence of hypertension is about 50% in women, 50% in men, 44% in women. And when you look at the younger age groups, those differences are a little bit more or a little less subtle. In 18 to 29, 20% of the men have hypertension versus just 9% of the women. And then between 30 and 44, 40% of the men, 23.7% of the women. The disappointing thing is the general practitioner approach to treating hypertension. This is from a study that came out and was published in the guidelines. Look at this age group, and here, the gray bars here tell us that the recommendation for those younger patients was to just try to control to below 140/90, which is not what the current guidelines tell us, should be below 130/80. I think that another thing that is relevant to the cystic fibrosis patient population is secondary causes for hypertension and things to look out for before we start medical therapy that we can potentially work with and decrease. Obstructive sleep, I put the top three, the more important ones at the top here in red. Obstructive sleep apnea is definitely present in up to 50% of our hypertension patients, and this is a very important intervention opportunity. Drug or toxin induced up to 20%. And then primary hyperaldosteronism, which I think is very important and very commonly missed, that combination of slight hypokalemia and blood pressure that is resistant to other medications is very common. And so those would be the patients who would respond to medications such as spironolactone. And other causes are here below. Another important etiology is medication-related hypertension. This is something that you probably know much better than me, but those are some of the usual suspects, NSAIDs, steroids, decongestants, and so on. So this is something that we can potentially work on before starting therapy or recommending lifestyle modification. And the guidelines tell us that for our borderline risk patients, 5 to 7.5%, who have stage 1 hypertension, again, 130 to 139 or 80 to 89, we should recommend lifestyle modification. Repeat in 6 months. If that doesn't work, start a medication. If they have stage 2, above 140, start a medication. And then for the intermediate and high-risk patients, just start a medication at stage 1. All right, so you've been wonderful cardiologists. You treated your patients' cholesterol and blood pressure values, and they're right where you want them to be. Unfortunately, their higher CRP levels keep them at higher risk of cardiovascular disease. And this is what you see here in the black bars. Patients who have normal cholesterol levels with treatment and normal blood pressure control are still at a higher risk for the CRP levels. And unfortunately, there's not too much that you can do about that. In the general population, there have been some studies looking at anti-inflammatory medications such as colchicine, anakinra, and other stuff. The results were mixed. I'm not going to go into this. They didn't work in all the studies. And so you have patients with higher residual CRP levels, which places them at a higher risk of cardiovascular disease. And the solution for that may be coronary artery calcium scoring to better risk stratify them if that's an interest. We call it CAC scoring. It's a terrible name, but that's how we say it, CAC. And it does in the general population perform better than inflammatory markers in risk stratification. We use minimal, it's really low dose radiation, and that's almost not a concern. And importantly and interestingly, you do get higher coronary artery calcium scoring in patients who are treated with statins, because statins would stabilize the plaque and make it more calcified, less prone for rupture, but you will see more calcium in your patients who are treated with statins. And these are just some examples. So here on the top left, no calcium in the left main. Yes, in the left main coronary artery. Top right is just this little spot in the proximal left main. Bottom left is more calcium, and then bottom right is a very calcified LAD. Very importantly, scans may miss soft plaques, what we call soft plaques, who have no calcium in them. That's how coronary artery atherosclerosis begins. And so it may be missed in younger patients. We have ways to overcome that in CTs, not a topic for this talk, but we can overcome that. And I think that this is an important table because it tells us what to do with our patient's calcium score. The calcium score is not relevant for the low-risk patients. You shouldn't have sent them to the CT to begin with, by the way. And for the higher-risk patients, they're already indicated for a statin, so unnecessary to send them to get a CT. It's very relevant for the intermediate group. So if their calcium score is 0, you don't need to do anything with them. If it's 1 to 99, you can consider repeating CT in 5 years, or with shared decision making, start moderate intensity statin if it's like 9, if their score is like 95. Even if it's over 100, you should start statin therapy. So it helps us to refine the risk in the intermediate group. And this is just a flow chart summarizing everything that I just said. For the lower risk patients, lifestyle modification. If you're unsure, do risk stratification with coronary artery calcium scoring, and recommend drug therapy and lifestyle modification. And from our endpoint in cardiology, lifestyle modification means more than 150 minutes per week of exercise plus 5 to 10 minutes of resistance training. Fruit, vegetable, nut, oily fish rich in omega-3 diet. Omega-3, it's interesting because there was a signal that capsules can cause atrial fibrillation, so we're not recommending them formally. And then moderate alcohol consumption. And I'm just going to finish with my kind of look into the future of cardiovascular disease in cystic fibrosis patients. I think that we're getting close to this paradigm or this cartoon here showing that your patients are going to be very similar to the general population. We're going to be seeing more metabolic syndrome with cholesterol, diabetes, and obesity. The chronic inflammation is kind of a given thing. And then you're going to see more hypertension. And all those three things are going to contribute to cardiovascular disease in cystic fibrosis patients. The gaps in knowledge, as I alluded to, traditional risk factors and risk calculators are not validated for CF patients. Trending inflammatory markers, we're not sure if it has the exact same meaning as it does for the general population. And then there is no consensus on the age or frequency of CVT screening in cystic fibrosis. Despite all that, I think that we can build a model to improve the cardiovascular health trajectory in patients with CF by doing the following four things. We should incorporate cardiometabolic surveillance in CF clinic pathways, and you can do that, PCP can do that, or we can do that in cardiology. Lifestyle counseling is definitely something that is warranted. Say to your patients to us. I mean, I think that many of us are happy to see primary prevention cardiology patients and help you manage patients with hypercholesterolemia, high calcium scores, and so on. And then, of course, longitudinal studies to look at the outcomes of patients on medications who have high CRP levels, blood pressure, et cetera, and what it means for the cystic fibrosis patient population. And then one final thing. I looked at this graph of your patient survival trend, and it really reminded me of something. And now I'm going to take off my general cardiologist hat and wear my adult congenital heart disease hat, because that's what I do for a living. It reminded me of this publication that came out 10 years ago in Circulation, looking at our ACHD patients who showed the exact same trend in survival. We're now looking at about 70% of congenital heart disease patients being adult, 30% being kids. And when I go back to this cardiovascular MACE outcomes of patients with cystic fibrosis and the fact that heart failure did not come out as more prevalent than the general population, I go back to my patient population and this publication in 2018 that came out of Europe, in which heart failure for the first time became the most prevalent type of heart disease or cardiac manifestation in adult congenital heart disease patients in the number one cause of death. So I don't think that it's going to be the number one cause of death in cystic fibrosis patients, but definitely down your alley. And until then, thank you very much for your attention. Happy to take questions.
That's very good.
Thank you.
I was curious about the role of GLP-1s in inflammation and cardioprotection.
Yeah, I was kind of expecting that question. When you look at I think that it's difficult because when you look at the studies that examine GLP-1, and I'm again zooming out to the general population, they were found to be helpful in two patient populations. Number one are the obesity, high weights. It depends on what study and what type of GLP-1 agonist you're looking at. And number two are the type 2 diabetes, not the type 1s. I saw that study that was shown here before. I thought it was interesting, but very, very small. There were some markers that GLP-1s decrease the amount of inflammation, decrease CRP. It did not come out as statistically significant, if that's a question.
Hi, Cindy Fort Worth. I had a question about whether there is data or anything about the CF diet that we had told our patients to eat for all these years and how just terrible it was for you, and if that's playing any role in the increase in cardiovascular disease in CF patients.
I saw that when I prepared for this talk. I saw that. It made perfect sense to me that it will. I haven't found any data but yeah, it made perfect sense to me. And I think that my guesstimation would be that the answer would be yes.
I have a question from the virtual audience, and it's a comment about a study that it looks like it was mentioned in the US News yesterday, and it was about a 60% reduction of utilizing estrogen replacement, menopause society study. And it showed, like any decrease in heart attack, stroke, breast cancer in women using estrogen perimenopause. Any comments that you have about that? And its application in CF, we're going back to the same thing.
I will say that I haven't seen that publication. I think that when we consult, again, the general population about estrogen use in cardiovascular disease, we absolutely tell them that we recommend to try and avoid as much as we can estrogen use and to do more or either nothing or more something that is progesterone based, not only during menopause, by the way, but just for contraception as well. Again, going back to my other adult congenital heart disease hat for patients with prosthetic valves, for patients with atrial arrhythmias, all those things, we try to avoid estrogen use. So yes.
They were the opposite here, it's replacing it. But.
Does the shift to the new AHA prevent calculator change, like the treatment thresholds that you had shown before for the ASCVD calculator?
It's a good question. I didn't mention that. Again, I had 20 minutes to go over cardiovascular risk reduction, but there is a new risk calculator that is being developed or was developed by the American Heart Association. It's utilizing slightly different risk factors. It's incorporating more things, and it gives you like a 30% or 30-year look into your patient's future in terms of developing atherosclerosis and cardiovascular. It's called the Prevent risk stratification tool. You can find it online as well. It did not make its way into the most recent guidelines. I am 100% sure that it's going to be there in the next guidelines. You can look it up, and I think it will answer your question. The answer is yes.
So this was great. This is a great talk. Thank you. I had a question kind of going back when you were talking about statin indications, specifically for statins with patients with diabetes. So I have a primary care background. Everyone who's 40 and over with diabetes, I'm like, you should be on a statin, but there are not guidelines for statins and CFRD that I could find on the CFF website. I have looked into this extensively because I'm putting together some resources. And I was just curious if you could speak a little bit about that.
Yeah, no, there are no guidelines. But if you go back to that risk modifiers thing on the ASCVD risk score, I think that many of your patients would just hit more than one risk. And the CRP thing is definitely one. I think the chronic inflammation is extremely important. And I think that statins have been shown, opposed to GLP-1 agonists, to reduce inflammatory markers and control inflammation better. My guess is that, and if you were like to borrow some information from the HIV world, for example, they would start statins at a much younger age and completely disregard that 40 cutoff. That would be my approach, especially if your patient has, more than one of those risk modifiers.
So the biggest issue is that there's an interaction with ETI and all others. It's not a very strong interaction because I've looked into this as well.
Okay.
But that has come up, and without having a clear guideline, it's so hard to then say you should be on this med that interacts with this other med that you have to be on.
Yeah, I'm happy to continue the discussion afterwards, but we do have other medications. So there is ezetimibe, there is bempedoic acid, there are PCSK9 inhibitors, things that we can use to prevent those interactions. There are other options.
So think about it. Thank you.
Kathy, last question, hopefully.
Kathy Ramos from University of Washington Adult Program. Thank you for your talk. Thank you for coming to our conference. And this is maybe a PCP overlap question here, but I frequently will see that my patients who are adults have high blood pressure sometimes at some clinic visits, and then it's normal again. And at what threshold should we be looking for these secondary causes of high blood pressure like OSA or their hyperaldosteronism?
It's a great question. I think that in an ideal world, we would put all of those patients, and that's what I try to do. It's just very difficult, and blood pressure halters. And it's a tool that is available to some extent in cardiology and at UW, as you probably know. It's sometimes there's this lack of availability. And so the other thing that I ask many of my patients to do is just to get a blood pressure cuff and measure their blood pressures at home. They may come to clinic and their blood pressure would be high because they're excited to see us, or they just had their echo and they're like anxious to see what the results are. And so I just have them measure their blood pressure at home and send me a log. Now that there's like a dedicated, I wouldn't even call it an app, but something in Epic that they could just log in their numbers. And so we just open it and see their numbers. To me, unless their numbers are like really 160 over 90 or something when they come to see me, which are like really high, that's probably the best way to screen a patient for true hypertension.
And if we're seeing the hypertension in our 20-something or 30-something-year-olds, does that raise your suspicion that it's something else? Maybe it's their trikafta potentially contributing.
I usually, for those ages, and again, not having too much experience in the cystic fibrosis world, I do a full workup for secondary causes of hypertension. That's just my practice.
Thanks.
Thank you, Dr. Buber. And so I have the pleasure of introducing the last speaker of the day is Dr. Stevenson, who is a staff respirologist at St. Michael's Hospital and Associate Professor of Medicine at the University of Toronto. She's a Registry Director for Cystic Fibrosis Canada, has published multiple studies that how to use registries and how we can learn from them.
Thanks, Dennis, and thanks for the invitation to speak today. I'm going to be talking about cancer screening, which is a little bit out of my wheelhouse as opposed to registry stuff. But these are my disclosures. Over the next 20 minutes, I'm just going to describe some of the cancer screening recommendations in CF specifically across the lifespan. So that's really what we should be doing. And then summarize some of the literature on cancer screening about what we're actually doing, and end with future research opportunities in this area, because I think there's a lot of things that we could be doing. There's a lot to learn still in this area. And as people have mentioned, the landscape is changing, more adults. This is from the Canadian CF Registry, and the proportion of adults over the age of 18 is 66% in 2024. So clearly our adult clinics are getting larger and larger. The pediatric clinics are staying about the same. And there are unique aspects to CF, it's sort of been alluded to, but that increase the risk of certain conditions, and cancer is no different. CFTR is considered a cancer suppressor gene, so that's one risk factor. The increased inflammation is another risk factor for developing cancers. And when we talk about cancer screening, often people go directly to GI cancers because that's really what we know a lot about in the setting of CF. And I just want to point out a couple of things from this table. So this is a table from a review that was published in 2021. It talks about a lot of different articles. But the first thing is the type of cancer in the GI tract. So it can range from anywhere from the esophagus all the way down to the rectum, although colon cancers, when you look at the incidence rates, are the highest in CF patients. But you can get cancers in the small bowel, biliary tree, pancreatic gland, etc. And when we compare this to the general population, we see that actually, although those numbers don't look really scary and really large in CF, when you compare to the general population, the risk of developing these cancers in CF is much higher than the general population. And furthermore, they occur at younger ages. So we need to be thinking about this, and I'll talk a bit about this in other cancers, but we need to be thinking about this earlier in life, not the typical age ranges where you'd be thinking about doing cancer screening. So colorectal cancer screening, people are well aware of this. This is a table that I just put together that talks about the age at which we start screening. So of course, post-transplant patients are at even higher risk. We start screening at an earlier age, 30 years of age. Non-transplant CF, it's around 40 years of age. And that compares to the general population, which is older. I did put Canada and the US here, the ages at which screening starts. But really, I would say check with your national guidelines because it does change depending on the country. As well, the frequency of repeat colonoscopies, depending on whether it's completely normal or whether there's a polyp found, it would be more frequent if there's polyps. And again, that's more frequent in CF compared to the general population. And the last point on this slide is really the screening test. So colonoscopies are what we would recommend for people with CF to screen for this type of cancer. In the general population, there are other options. The fecal immunochemical occult blood test is another one, which is of interest to patients with CF, so they don't have to go through a colonoscopy. So it would be interesting and useful to know how that works in CF. So a few words about this test. These are three sort of common tests that you can use. They're stool collection tests that check for blood in the stool. The first one really is one that is not specific to the lower GI tract. It's one that I used when I was a resident in the Emerge, kind of checking to see if there was any blood in the stool. They're not really used very much now. It's more the immunochemical test, which is an immunoassay that checks for the presence of hemoglobin. And the sensitivity is fairly high, 70 to 80%. It is specific for lower GI tract bleeding. And if it's positive, one would go on to a colonoscopy. But now there are these other more sophisticated tests, which are not only looking for hemoglobin, but also looking for DNA markers, or basically abnormal cells or DNA that are shed by the cancer. And that is more sensitive, 92%, but it's more expensive. It's not readily available necessarily everywhere. So the FIT test is kind of what the recommendation would be for CF. Sorry, not for CF, for the general population. That test is not extensively evaluated in cystic fibrosis. And this is an abstract that is presented at the conference, abstract 575, and it was presented in an earlier workshop today, actually. And they compared stool-based testing to standard of care. So they did both the FIT DNA, and colonoscopy. And I encourage people to go and check out the poster, but the bottom line is there was very low sensitivity for the stool screening measures for in this population, so it was not recommended for screening. So really colonoscopy is still the recommended test for screening. And this is a publication that came out recently, just last month, I believe, in 2025, a study from the UK with 113 eligible subjects. And they also compared FIT testing with colonoscopies to see how well the FIT test was able to identify polyps in this study. And some general findings were that essentially 58% of subjects returned the FIT test. So it was a test that people were using, although that's lower than the general population. The bowel prep, which is sometimes a concern in CF, was adequate in 82% of the patients, so that was also reassuring. And the prevalence of polyps was 27% in this study. But again, they also found that the sensitivity for FIT testing was low at 14%. So the conclusion from this study was, again, not to recommend FIT testing for screening in CF. So the take-home message there is colonoscopy is really what we need to be doing for screening at the moment. For non-colorectal cancers, I mentioned that it can occur anywhere in the GI tract. There are some biomarkers for some GI malignancies. CA19-9 is a biomarker, and that's elevated in cholangiocarcinoma, pancreatic cancer. The problem with that biomarker is it can actually be elevated in cystic fibrosis patients, so doesn't necessarily mean that that person has a cancer. And there are really no clear recommendations of which tests should be used for screening for non-colorectal cancers in the GI tract. And I wanted to highlight another abstract, number 724, that was looking at pancreatic cancer and MRCP-based screening protocols. And again, I encourage you to go and look at the poster, but essentially the authors did find that there was a fairly high percentage of people who had these intraductal papillary mucinous neoplasms, IPMNs, and they're felt to be precursor lesions for and have the potential for malignant transformation. So they suggest that this might be a useful screening tool for pancreatic or biliary cancers in the future, but the jury's still out on that regard. For liver cancer surveillance, the screening, evaluation, and management for hepatobiliary disease consensus recommendations were published in 2024, and they do talk about surveillance for liver cancer. And this is really only in the setting of cirrhosis. So if someone has cirrhosis, that increases the risk that they could potentially develop hepatocellular carcinoma. And they talk about ultrasound being a cost-effective and easy-to-perform evaluation technique. And alpha-fetoprotein is another biomarker that might be, that is used for these cancers and is associated with the prognosis and mortality of hepatocellular carcinoma. So the recommendations in these guidelines are basically in people with cirrhosis, in children to do annual ultrasounds and serum alpha-fetoprotein, and in adults, ultrasound and serum alpha-fetoprotein every 6 months. But there are lots of other cancers. So talking about other cancers that we have really good screening tools for, breast cancer being one, where we have mammography. Really, there's no CF-specific recommendations. People should be following national recommendations. But interestingly, there's not a lot of literature on this, but there was a study, a UK study using registry data published in 2022 that looked at a whole bunch of different cancers, but breast cancer was one of them. And they comment in the discussion that the rate of breast cancer in this population, their population, was higher than the general population. So there was concern that maybe breast cancer is happening more frequently in CF. And as people age, we may see more of this in the future. And it's possible that breast cancer is starting at an earlier age. So, in Canada, we start breast screening at age 50. Maybe this should be earlier, but I think we need more data to make recommendations. For cervical cancer, pap smears are a good way to detect cervical abnormal cells and screen for cancer. Again, following national recommendations is what I would suggest. There's no specific CF guidelines, but there was a French study published in 2017 that I just wanted to highlight, where they had 47 women that were included in this study who had abnormal pap smears. Out of those people, 25% of the non-transplanted patients and 33% of the transplanted patients had abnormal paps. So again, there are atypical squamous cells, other kinds of abnormalities that we're seeing, and this is a higher proportion than the general population. So it may be that cervical cancer is higher in CF, but we just don't have enough data. Skin cancers, usually that's sort of annual skin exams, just in general, again, following national recommendations. It's interesting that in the UK study, they did comment that skin cancers were higher than the general population as well, and they suggested that this could be due to some of the antibiotics that we give people do increase sun sensitivity, as well as other post-transplant medications as well. So that could be a risk factor for developing skin cancers. So how are we doing with cancer screening in CF? This was shown in an earlier talk in this session, but basically this was a chart review, 92 subjects. They looked through the patient's charts for a bunch of different screening recommendations to see if it met the criteria. And you can see the cervical cancer, mammography, and colon cancer are shown there. Not great in terms of mammography and cervical cancer screening. Colon cancer was better, but actually was a little lower than I would have anticipated given the known risk factors in the CF population. And this is a recently published paper in a Danish cohort looking at basically the uptake of colorectal cancer screening in their population. They looked at patients who were 40 years and older, or 30 years and older if they were transplanted. This is one of the fewer studies that actually showed people on modulator therapy, because a lot of the other research that I talked about was pre-modulator, so 76% were on modulator therapy. And they commented that there was a high adherence to screening, so that was good. 84% of those offered screening for colorectal cancer actually received it. But there was some room for improvement, and 25% of the patients were not referred for screening colonoscopies. And they also commented about the bowel prep being excellent in 72%, which is good because obviously it's not great if people have to have a second colonoscopy because visualization was bad because the bowel prep didn't work. So that's reassuring. We did a study in Ontario which linked the Canadian CF registry data with the health administrative databases in Ontario. And this is a map of Ontario. It's small numbers, but in Ontario, that's about a third of the CF patients are followed in Ontario. And the benefit of doing this linkage was we had the clinical information from the registry and the health administrative databases that captures all detailed information on procedures that are done, contact with healthcare providers, admissions to the hospital, ER visits, outpatient visits, and a whole whack of other things that are available in those databases. And a lot of the things in those databases are not available in the registry. So having the two of them together was a really powerful resource. And we looked at cancer screening in CF using this database over a period of time, 2012 to 2022. We created eligible cohorts because they were all different depending on if we were looking at breast cancer, cervical cancer, or colon cancer. The ages were different. Obviously, the sex was different. And we used validated algorithms to identify screening procedures. So the health administrative databases at ICS have looked at this in many populations. So we used those algorithms. We were able to identify who had a screening procedure and who didn't, and looked at ever screened. So this was just a first pass look at it, not at whether they were receiving appropriate screening over time, but whether they were ever screened. And this is a table just showing the results for the different cancers. You can see the age ranges there and the sample sizes, but basically the percent screened ranged from 46% to 67%. So surprising to me, breast cancer screening was actually pretty high, 67%. Now, this might be because there is an Ontario breast screening program within the government. So people get letters sent out to them, which has nothing to do with the CF program. So the proportion was probably high because of that as well. And also, I was a little bit surprised at the colorectal cancer screening numbers, 50% roughly for pre and post-transplant. Again, because we all know that that is definitely CF as a risk factor for colorectal cancer. So I was a bit disappointed that we didn't find it was a little bit higher. And then just speaking about primary care providers and the importance of these individuals in the care of CF patients, we postulated that having a PCP would actually increase the risk or the chance that you would be screened for certain cancers. And sure enough, we found that the chance was higher for breast cancer, cervical cancer, and colorectal cancer in the pre-transplant population. So people who had a PCP were more likely to receive the screening tests for those three. Not so for post-transplant colonoscopies or colorectal cancer. That may be because the transplant program is very aware of that risk as well, and it may not be that the PCP plays a large role in that post-transplant population. But again, I think this is more evidence to suggest that we really need to engage primary care and make sure that they're part of the CF team moving forward as the population ages. So some of the gaps in the literature, there are very few prospective cancer studies, and obviously these things take time. It's not that the rates are really high in absolute numbers, so you have to follow people for a long period of time. Most of the literature focuses on colorectal cancer, but we really need to look at other parts of the GI tract as well as non-GI cancers in terms of the prevalence and also screening for those. And I mentioned about thinking about other non-invasive screening methods for cancers, particularly in the GI tract, I think would be really helpful. Some of the literature that I showed about the FIT test, the fecal occult blood test, some of the problems with that is that the sample sizes were relatively small. The number of people who actually had colorectal cancer or polyps was low. So, it's hard to say. We might need larger studies to actually say for sure that that test is not useful. A lot of the literature, of course, this is probably the case in every single talk. A lot of the literature is pre-modulator. We need to do everything all over again just to see, because obviously modulator therapy may reduce the risk of cancer, but it needs to be studied. Maybe it's going to, because it's making the CFTR protein function better, that's going to decrease the risk. It's decreasing inflammation. Maybe that's going to decrease the risk. So we'll have to see what the literature shows in the coming years. And I really think that there's an important need for registry integration. I do always try to bring the registry into every talk that I do. I will admit that. And I think, a lot of the registries are thinking now about these emerging complications, including cancers, and many of the registries already capture that kind of information. But the UK study that I mentioned on an earlier slide, I was interesting because the largest number of cancers in their table was actually unknown. So we don't know what those cancers were because they said they had a cancer, but we didn't know the organ. So it's important that we collect information on not just if they've had a cancer, but where the cancer is. And if we can capture information on screening, so, we would know using just registry data if people are being screened, of course, that also would be great. And finally, just considering linkages to pre-existing databases where possible. I gave the example of the Ontario project that we worked on where we linked it to the health administrative databases. But there are lots of registries. There's cancer registries. There's other things. And believe me, there are barriers to doing these linkages. I'm not saying it's an easy thing. Even doing that linkage to the health administrative databases, I think took me about 9 years, to get through all of the hoops and the jumping through all of those to make it happen. But I think if you don't give up, there is a way to do this. And it's very powerful when you have these combined registries, and it reduces the burden on the CF clinics to collect all of this information themselves. So the key take-home messages here are, as you've heard from everybody who spoke today, there's longer survival in CF. The prevalence of these things is going to increase. We really need to think about cancer screening. That is how we're going to detect these things early, and we're going to prevent deaths and allow people to be cured from cancers. Looking at your own registry data is important as well to see how you're doing on screening. Develop QI projects and algorithms and reminders, because it's hard to remember when somebody had their last, colonoscopy, for example. And then non-invasive tests, I think, need further investigation in larger samples, as I mentioned, and engaging the primary care providers. I think it's amazing the people that have spoken and asked questions today, and some of the other speakers who have talked about ways to engage primary care. I am going back home and I'm going to look up some primary care people around our center and see if we can engage them, because I think we do need to educate people about the massive changes in the landscape that we've seen in CF. And maybe we need to publish some papers in primary care journals and, sort of get that message out there so that people are aware. And with that, I just want to acknowledge the team who was involved in that Ontario study, patients and families who agreed to participate in the Canadian registry, but all registries, and the funding that we received for that particular study. And I'm happy to answer any questions.
Thank you, Dr. Stevenson. While we're waiting for anybody to come up, one question from the virtual participants. Is there any downside to try and do MRCP screening for pancreatic cancers, other than the fact that it's costly and it's also difficult to approve from insurance, at least in the US, and maybe, other problems elsewhere?
Yeah, even in Canada, it's just not easy to get that test done, and you're waiting for a long time and coordinating it with the patients. And it's in theory, I think it sounds like it would be good, but because of the lack of radiation and all those things, I think there's not a lot of downside outside of cost and time. But I think the jury is still out on whether or not that's a good screening tool to begin with, to be honest. So I think we have to answer that question first.
Yeah, and also over-screening sometimes can lead to more testing and more
Yes.
biopsies and all that stuff. So.
Yes, for things. And just anecdotally, we had a young woman who recently was diagnosed with cholangiocarcinoma, and it was sort of in retrospect, looking at a previous scan, that the radiologist noted that there was some abnormalities, and unfortunately, by the time that she was diagnosed, then these cancers can be very hard to identify. But she did have an MRI, and unfortunately, it had spread already by the time it was finally diagnosed, and it's a really tragic situation. So I'm not sure these cancers are happening, but I'm not sure what the best way is to identify them really early and make the diagnosis, because it's sometimes very difficult.
Anybody else from the audience? I'm going to ask a question myself, so this is more speculative. So a lot of those cancers are from a time when we didn't have modulators, and now that we have modulators, are we going to see cancers that are more common in the general population, maybe drop in the colon cancer, but maybe we'll see more of things that might have to do with lifestyle or, obesity, metabolic, syndrome?
Yep. I think that, as was the message from a lot of my colleagues up here, that, the recommendations need to change for lifestyle changes and, decreasing obesity, decreasing inflammation, all of those other things. And I think that will make a difference. But the modulator question, I think, is really uncertain. In theory, I think it hopefully will reduce that higher risk that CF patients have to develop some of these cancers at earlier ages. But, they might develop cancers. It just might not be at the earlier ages that we were seeing.
Thank you.
Thanks.